Okay, so I'm going to start and read this in English, and then Antonietta will translate into Spanish, and then at some point we'll switch into Spanish and English channels. But for now, we're going to stay in the same room, so don't touch anything on your interpretation. Welcome to the San Fernando Valley Out for Mental Health virtual conference, Healing Through Lived and Shared Experience. I'm Nicole Crystal. I'm president of Still Bisexual. I run the San Fernando Valley Task Force, which is part of Out for Mental Health. Out for Mental Health is a statewide project that advances mental health equity, provides resources to build capacity in local LGBTQ+ communities, and represents a coalition voice at state level policy discussions. Task forces meet regularly to work collaboratively on mental health policy change. Policy objectives are identified by local LGBTQ mental health stakeholders and based on the needs of their specific community. Task force leads and members are supported with exploring current county system resources and policies, identifying decision makers, and finding opportunities for change. Okay, Antonietta, go ahead. Be sure you're in the English channel, I think, or wherever the main room. Can you guys hear her? No. Antonietta, are you in the English channel or the main room? Well, we haven't told people how to go in the Spanish room yet, so just do it in the main room, please. Okay, go ahead. Yes, please translate it in this room where everyone can hear you because we haven't split off yet. All right. So Still Bisexual, my organization, just quickly, we're a national Biplus Advocacy organization that uses storytelling, education. Okay, and I assume those of you who read it in English saw it as well. So if you want to go now, we're going to switch into Spanish and English channels. So if you're So now Antonietta switched to Spanish. Everybody who wants to hear in Spanish, switch to Spanish by clicking on this and choosing Spanish. And everyone in English, you need to select English. Okay, so hopefully everyone's gotten into the language they want. And I will introduce our presenters, Brian Navarro and Rebecca Gitlin. Thank you for being here.
Thank you for having us.
So go for it. I will stop my video and stop taking up.
Okay, great. So I'm going to go ahead and share my screen. Ooh. Here we go. Are we sharing? Are we good? Okay, cool. And before I go into full screen mode where I'm going to lose all of you, at least being able to see your cameras, our presentation is called Caring for Each Other and Caring for Ourselves. We're going to be talking a lot about common mental health concerns. And so as part of a way to tailor our presentation to what your specific needs are, we'd like to ask you a question before we get started. A moment. So what I would love is a show of hands. And so you can use the reaction button at the bottom of your screen to raise your hand. How many of you are mental health clinicians? So a psychotherapist or a psychiatrist, and or how many of you have already had training in mental health diagnosis?
I think I see one hand, 2 thumbs up and a one hand.
Two thumbs up and a one hand. I'll take it. All right. So it sounds like most of us here are not mental health clinicians or have not had this training. So we will, we'll change that today. You'll have some information after this afternoon on what different diagnoses look like, how we define them. Oh, sorry. Of course, so sorry. I'll just go into our presentation.
Did you want to introduce yourself?
I sure do. Thank you, Brian. So my name is Dr. Rebecca Gitlin. My pronouns are she, her, and hers.
And my name is Brian Navarro. I'm a clinician here with the Department of Mental Health, and my pronouns are he, him, his.
And I am a psychologist by training, and I am currently working as the LGBTQ plus services specialist for DMH.
And I'm a licensed clinical social worker. My emphasis is in children and families. For the department currently, I'm the health, neighborhood, and faith-based liaison for West LA. And so we wanted to during this presentation, we're going to be periodically checking in with folks. We have a lot to cover. Today, we would like to provide a definition for mental health, discuss trauma-informed care, share a little LGBTQ history, discuss minority stress, before exploring contributors to mental health, such as adverse childhood experiences. Let's start by providing a definition for mental health. Mental health includes our emotional, psychological, social well-being. It affects how we think, feel, and act. It determines how we handle stress, relate to others, and make choices. Mental health is important at every stage of our life, from infancy through childhood, adolescence, adulthood, and into older adulthood. Next slide. What you see here in this slide is a path that splits and diverges from the main path. Our path does not always steadily move forward. I wanted to provide this picture really as a metaphor for today's training about mental health and mental well-being, that even in our life, we don't have a straight line, that we should expect a few twists and turns on this journey. There are times in everyone's life when one needs a little support for these difficult situations. Like I said, no path is straight. Dr. Gitlin?
Great. So this is a framework that I use for all of the work that I do in mental health. It's a framework called trauma-informed care or trauma-informed practice. So This slide is very busy, so I'll give you a brief summary of what trauma-informed practice entails. So what we are now really starting to understand in the field of mental health is the really far-reaching impact that trauma and other adverse experiences have on a person's health and a person's well-being in lots of different ways. And so what trauma-informed practice asks of us is to recognize how common trauma is and what kind of impact it can have on someone's healthcare and someone's behavior and their relationships. When we have this recognition, we're able to shift our behavior and shift our lens into how we understand suffering and pain in a way where we're not going to accidentally re-traumatize the person that we're working with. So one of the main ways that we go about this shift is starting with the way that many of us were trained, which is to start with the question, what's wrong with you? You know, what brought you into my office? What's not going well? So instead of asking that, we instead want to start with, what happened to you? What have you experienced? What have you survived to come to this moment in time that might be impacting the way that you are navigating your life? And even beyond that, we also want to know what's strong with you. Even when folks have gone through some really, really tough times, we all have strengths and we all have aspects of our cultural backgrounds and our identities that are really core to who we are and part of what gives us strength to move forward through those hard times. So that's a really key part of a trauma-informed approach to this work. One of the reasons why it's important to talk about trauma, and especially with our community, is to really think about the collective history that we might be carrying with us every day and bringing with us into a mental health setting. So I'm not going to read through every single one of these for the sake of time. You can read through them on your own. But the 3 points that are highlighted in blue, those are specific points of history that are related to the history of psychiatry and stigma against LGBTQ plus people. So, you know, up until the early 70s, it was considered a mental illness to be gay or to be attracted to people of the same gender. So that was removed in the 70s, but for a very long time, that was a reason why people were labeled as sick or unwell. We also really want to acknowledge the history of really harmful practices that are meant to change people's sexual orientation or gender identity. It is referred to as conversion therapy, but it is not therapy at all. Not only is it ineffective, but it can be incredibly harmful and traumatic. Those are starting to get banned or prohibited more and more in various places. Most of those bans are only for young folks and for mental health providers specifically. So these change efforts are still happening for many people and may not be happening in mental health, but might instead be happening at home or in a faith community. So most recently, in terms of diagnosis, we're seeing a shift from gender identity disorder to gender dysphoria. That is essentially the diagnosis of trans identities that you find in mental health settings. So even though the name has changed, the pain and the stigma that is often associated with that label has not changed. We'll talk a little bit later about gender dysphoria a little bit more. The last 2 points that I want to highlight here are ongoing events that are happening within our community that are really impactful to many of us and that really might impact the mental health that someone has and the work that they're doing in therapy. So we see disproportionately high numbers of deaths by suicide among young folks in our communities. And we also see highly disproportionate numbers of murders of transgender and gender non-conforming people, particularly Black transgender women. So again, from a trauma-informed framework, I just want us to kind of hold these things in mind. Why do we hold these things in mind? So we know that members of our community have particularly high numbers of various psychiatric diagnoses. We know that members of our community have higher rates of suicidality. We also know that folks from our community have much higher levels of victimization and discrimination that they're experiencing. So we want to think about the relationship between those two things. In terms of social determinants of health, we're looking at really high levels of homelessness or housing insecurity, financial insecurity, and unemployment or underemployment. And those disparities were all in place before the pandemic. So we know intuitively that they have only gotten worse during the past year and a couple months. And I also really want to note that these disparities are not the same for everybody in our community. We see especially significant differences, higher levels of psychiatric distress, of these social determinants, and victimization and discrimination experienced by transgender plus folks and bisexual plus folks. And that happens both within a healthcare context and in our society at large. One of the ways that we understand why these disparities exist is another framework that I'll share with you called the minority stress framework. So the minority stress framework puts forth that in addition to the daily stress of just being a human being who is navigating our society, that for people who have identities that are historically oppressed or marginalized, there's additional daily stress in navigating a world that is hostile or discriminatory toward people like you. And that additional stress can lead to differences in coping behaviors and other health-related behaviors that can eventually lead to differences in diagnoses. So where do we see minority stress? We see it in our daily interactions with other people. We see it through institutional and structural discrimination. So that can be anything from culture and cultural customs to what our legislation says and allows, and also the way that people are portrayed or not portrayed in the media. So what does society at large see and therefore know about people in our communities? And we know that these experiences that happen outside of us are not in a vacuum, right? We internalize some of the beliefs that are expressed to us and about us. And so what we often find is that folks are living with internalized transphobia, internalized biphobia, and or internalized homophobia that can also impact some of the ways that we move through the world. As we think about these internalized kind of sources of stigma and sources of rejection, we also want to think about this intersectionally, which means that we also want to think about how our sexual orientation and gender identity intersect with our race, our class, our age group, our generation, our abilities, etc. So that none of this happens on its own. We're looking at relationships. One of the ways that we see minority stress potentially being kind of increased by larger cultural narratives are the things that we are told, especially younger folks in our community, the things that we're told about our own history. So here on this slide, we have kind of three of the matriarchs of our movement. So on the left, we have Sylvia Rivera, in the middle, Marsha P. Johnson, and on the right, Miss Major Griffin Gracie. So these are three femmes of color who are gender expansive, who were in New York at the time of Stonewall and really instrumental to the beginnings of our movement. They were all kind of either present at the Stonewall riots or very influential in the movement that came afterwards. So despite these three women and their leadership in our movement, when the movie Stonewall was released in 2015, this was the main poster image that is put forth. So here we see the person who is portrayed as throwing the first brick is not at all representative of the real leaders of our movement, right? So when we think about internalized stigma and collective narrative, it's really important also for us to take an intersectional and anti-racist approach to this.
Thank you, Dr. Gitlin. Dr. Gitlin discussed minority stress, really talking about some of the noise that really affects us, affects our mental health, and really wanted to talk about the spectrum of well-being. Depending on the circumstances of your life, at any given time, your mental well-being may fall at any point on this continuum. Mental illness or mental health disorders can impair the mind. It can impact how individuals behave, think, and interact with others. And it can create emotional behavior problems serious enough to affect an individual's daily functioning, making it difficult for folks to take care of their daily activities, including self-care and maintaining a job. When we conceptualize well-being, we think of illness and well-being on the spectrum, where illness and impairment in one's daily functioning is on one side of the spectrum, and well-being and optimal health is on the other side of the spectrum. We have some general signs and symptoms we are taught to look for when assessing an individual for mental health and well-being, but I think all of us here have an internal sense of when we're feeling well and when we're feeling unwell. Check in with yourself at this moment right now. What are some of the signs and symptoms you feel when you're not feeling well? And on the opposite end, what are some of the signs and symptoms of when you are feeling at your best, optimal well-being? What contributes to that well-being and what contributes to you not feeling well or stressed? Next slide. And so what contributes to our mental health? I mean, we understand that life experiences such as trauma and abuse, which we'll be discussing a little bit later in the presentation, has and can really profoundly affect people's mental health and well-being. We're also beginning to understand that biological factors such as genes or brain chemistry and how trauma can adversely affect the brain, we are beginning to understand that trauma can be can be passed down from intergeneration to generation, from your grandparents to your parents and from your parents to yourself. So family history of mental health also can contribute to one's individual mental health. We also know that substance use or misuse can also compound some of those symptoms. And we're also going to be talking about stress and how trauma, repeated trauma, loss, and grief, really when thinking about this past year of the type of loss and really chronic loss that we were experiencing this past year, how did it begin to impact how we think and how we behave? The next slide we're going to be seeing right now is going to be connected to some of those contributors of mental well-being. And we're going to be talking about or seeing a small video about the impact of adverse childhood experiences. We'll see this video, and then I'll tell you a little bit about how this study came to be, but it will do a good job at really describing how stress can really affect the individual, how it can affect the mind, and it might also talk about some mitigating factors, things people, situations, or institutions that might be able to buffer some of those negative impacts.
Awesome. So I was told to do this directly from YouTube. So bear with me, please. Okay. Can everyone see this? Brian, can you see my screen? The adverse childhood experiences video?
I see a blank.
Okay, great. Hopefully.
There we go.
We're good?
I hear the sound.
A child's experiences early in life are important building blocks for the developing brain. Genes, nature, are like the blueprint. They provide the basic framework for brain development. However, genes do not design the brain completely. Environmental influences, nurture, fine-tune how the brain works by shaping which brain connections get used. Connections that are used more grow stronger and more permanent, whereas ones that do not get much use fade away. Together, genes and the environment build the foundation for all future development. Safe, stable, and nurturing relationships early in life lead to healthy development. But children's brains capture other experiences as well. Stressful events. However, not all stress is bad. Positive stress involves normal childhood experiences, like starting daycare or meeting a new person for the first time. This stress is essential for healthy development because it helps children develop coping skills and confidence. But when stress is frequent, chronic, and uncontrolled, it is toxic to children, especially when they do not have a caregiver to provide support or buffer the stress. Adverse childhood experiences, ACEs, such as abuse, neglect, exposure to intimate partner violence, parental depression or addiction, and poverty, are toxic stressors which could lead to lifelong changes in learning and behavior. ACEs early in development can impact social, emotional, and cognitive functioning, increased risk-taking behavior such as drinking and substance use, and increased risk of disease, disability, and social problems later in life. The question is, how do adverse childhood experiences impact a lifelong development? One of the most important systems in our body is our stress system. It's activated when we experience stress. We become alert, our heart rate increases, and so do our stress hormone levels, cortisol and adrenaline. Our body is ready to react, what is known as fight or flight. A short period of time after the stress is over, or if a child receives support from a caregiver, the stress response turns off and the body returns to a normal state. Adverse childhood experiences create stress responses that stay active, and without the support of a caregiver, the system has difficulty shutting off completely. This constant and prolonged activation can affect immune system functioning and increase the chances of sickness, infection, and disease. Prolonged activation of stress hormones is also toxic to the brain. Certain areas of the brain are more vulnerable to toxic stress, including the executive center or the brain's control center, an area important for solving complex problems, attention, reasoning, impulsivity, inhibition, and learning. A second area is the emotional center, the brain's alarm system, which is involved in processing and interpreting emotions and the ability to control impulses. The third area is the memory and learning center, the brain's filing cabinet, which plays a major role in learning and the formation and retrieval of memories. Science shows that adverse childhood experiences impact all of these brain centers. Behaviorally, what we begin to see is emotional distress, poor emotion regulation, greater impulsivity, learning difficulties, and physical and mental health problems. More recently, science has begun to look at how ACEs cause changes in gene expression through a process called epigenetics, which helps us understand how nature and nurture interact. Epigenetics causes changes in the way genes work without changing the DNA code itself. This occurs through chemical changes influencing how the code is used. In other words, genes are like the hardware in a computer. They determine the boundaries of what is possible. However, we need an operating system to tell the hardware what to do. Epigenetics is like the operating system directing the function of a gene's DNA hardware. The genes we are born with are the genes that we have for life, but experiences like nutrition, exercise, smoking, stressors, and relationships all affect our biology. Adverse childhood experiences are associated with epigenetic changes related to stress, brain development, cognition, and systems associated with mental and physical health. Changes that happen early in brain development are more likely to be enduring and are possibly passed on to future generations as well. The good news is that positive, supportive relationships at any stage in life can make a difference. However, supporting families and children early on will help prevent many of these negative outcomes. One of the key ingredients for healthy development is having warm, loving, and actively engaged caregivers. This involves promoting serve and return interactions, where caregivers actively and warmly engage with the child, making eye contact, responding to sounds, words, gestures, emotional needs, and sharing experiences like reading and play. Providing programs that support caregivers to strengthen these abilities are the blocks that build healthy foundations for life.
Thank you. I think this video did a really good job at really trying to explain something very complicated, really the connection that stress, traumatic stress, whether from caregivers or the environment, can affect the individual, that it can affect brain chemistry, that it can affect our moods and behaviors, and worst of all, that it can affect our outcomes of reaching higher education, of having long, healthy lives. How did this study come about? We're really just finding these connections that stress or toxic stress having a connection on outcomes. But this came up in the 80s. Dr. Vincent Folletti, the chief of preventative medicine at Kaiser Permanente in San Diego, he was running an obesity clinic towards patients that were overweight. Over a 5-year period, more than half of the participants dropped out of the program, despite most of them losing weight. When he began to investigate using a series of questions why these folks were falling out of the program, he found a connection between the answers that they were answering on the questionnaire, saying that they were positive for abuse, specifically sexual abuse and trauma, and finding that connection with poor outcomes. So this is how this questionnaire came about, a recognition that stress, trauma, actually there was a connection to poor outcomes. Specifically in this study, it was increased weight and healthy and poor outcomes. This really lays the groundwork for some of the things that we'll be talking about, so that when we talk about some of the diagnosis, that we're really using a trauma-informed lens, a recognition that trauma that people experience can affect them, can affect their thoughts, behaviors, and actions. In this section of the presentation, we'll be covering a few types of psychological distresses. We won't be discussing specific situations or cases, nor will we be providing someone with a diagnosis, but we'll discuss the signs and symptoms of a few conditions, starting with anxiety. Anxiety is normal, an expected response to a challenging situation. Your body and brain are communicating potential threat of danger. Some anxiety is helpful. It can motivate us to get things done. This presentation's a good example. I was really anxious, but it really propelled me to put a lot of energy into this presentation, right? How do I know my anxiety is starting to become a problem? It comes out of nowhere and is much more intense than you would expect. It leads to focusing on the worst possible outcomes, even to a relatively minor concern or situation. It sticks around even after a stressful situation has passed, Oftentimes people are thinking about it, ruminating about it, having dreams about it. How does it begin to show up? How does it begin to manifest symptoms in our body? We begin to see some physical changes like restlessness, digestive problems, racing heart, sweating, feeling tired, sleep problems. In particular, people of color often report having physical health complaints, right? These might be types like your stomach hurts, right? You're having aches or feeling fatigue. How else can anxiety show up? Well, it can really affect our cognition or how we think. Sometimes we could start to think things are very terrible, or always terrible things are always happening. Kind of what if situations. Why can't it happen if it did it this way or that way? It can affect our feelings, feeling of dread, irritability, or frustration. And it definitely can affect your actions. Imagine if you're having these stressful thoughts, it's affecting your feelings. No doubt it's going to affect your behaviors or actions. So sometimes people would begin to avoid other people, places, things, or situations that cause them anxiety, difficulty concentrating. Anxiety disorders are the most common type of mental health concerns in the US at this time. Next slide. What are anxiety disorders? Anxiety disorders involve more than temporary worry or fear, right? Like I mentioned before, feeling anxious, it is part of our human characteristic, right? It helped keep us safe when we were living in jungles and there was animals out to attack us. Anxiety is a forward-thinking type of energy, right? Helps us keep us safe and begin to plan. For someone with anxiety disorder, though, however, that anxiety does not go away, and it could even get worse over time. It begins to interfere with your daily activities, such as your job performances. For little ones, it's going to affect their schoolwork. And then also it's going to begin to affect your relationships. Relationship with friends, could be relationships within work, or relationships with your intimate partner. There are several types of different anxiety disorders, and we'll be discussing a few of them. We'll be discussing generalized anxiety disorder and panic attacks. Two other ones that we also see are social anxiety disorders and very specific phobias. One that we often hear about is like arachnophobia, the fear of spiders, right? So very specific. Let's dive into the next slide, general anxiety disorder. It is normal, like I mentioned, to feel anxious, especially if your life is stressful. However, excessive ongoing anxiety and worry that are difficult to control and interfere with day-to-day activities may be a sign of generalized anxiety disorder. It is possible to develop general anxiety disorder as a child or as an adult. Living with general anxiety disorder can be a long-term challenge. In many cases, it occurs along with other anxieties or mood disorders in most cases. Generalized anxiety improves with talk therapy or medication. Also making lifestyle changes, learning to cope like with stress, using relaxation techniques can also begin to help you manage some of those symptoms. And so when we think about generalized anxiety disorders, they may include persistent worry or anxiety, overthinking plans and solutions to possible worst case scenarios, difficulty handling situations. Physical signs may manifest in fatigue, feeling extremely tired, right? Trouble sleeping at night. I think during this past year, there was a lot of reports about insomnia, having trouble sleeping, how some of that anxiety, that worry about what was going to happen to our families or our personal health began to interfere with our ability to have restful sleep. Nervousness and sweating could also be some of the physical characteristics one will feel when having anxiety. There are many times when your worries don't completely consume you, but you still feel anxious, even when there's no apparent reason. For example, you may feel intense worry about your safety, or that your loved ones or you may have general sense that something bad is about to happen, right? Your anxiety or worry or physical symptoms can cause you significant distress in schoolwork, and also other areas of your life, like I mentioned, relationships or relationships at work. Worries can shift from one concern to another and may change with time and age. And when we think about children too, children also suffer from anxiety, children and adolescents. In some of our younger children, it may manifest in them having trouble in school, conflicts with family members or siblings, which really seem normal on some extent, but when they become a little too much or too much fighting, then begin to take note of that. In some of our children, anxiety can also look like them becoming a perfectionist at school, super worried about getting their tasks done, redoing homework, or often redoing their writing because they don't want to make mistakes. At these times, these are times when to really think that it's beginning to interfere with their daily functioning, doing their schoolwork, or even having positive relationships with friends. At this time, this is when it's really good to think about getting help so that you can begin to address some of those symptoms. The next slide is panic attack. And many people just have one or two panic attacks in their lifetimes, and the problem goes away, perhaps when a stressful situation ends. But if you had a recurrent, unexpected panic attack and spent long periods of constant fear of another attack, you may have a condition called panic attack. Although panic attacks themselves aren't life-threatening, they could be frightening, significantly affect your quality of life, but treatment can be very effective. Panic attacks typically begin suddenly, without warning. They can strike at any time, when you're driving a car, at the mall, in the middle of doing a business meeting. You may have occasional panic attacks, or they may occur frequently. Panic attacks have many variations, but symptoms usually peak within the minute. You may feel fatigued and worn out after a panic attack. Panic attacks typically include some of these signs that are on this slide, which include a sense of impending doom or danger, fear of loss and control or death, rapid pounding heart rates and sweating, trembling or shaking. Oftentimes who experience a panic attack for their first time will report feelings of having a heart attack. And this is oftentimes something that people may assume that they're having. But there are ways to begin to combat and cope with having panic attacks. They're listed here on the slide. Some strategies to reduce the intensity of the panic attack might really, sometimes people say join with that energy. Do 5 to 10 jumping jacks, right, to expel some of that energy. Hold ice in your hand. Oftentimes when having a panic attack, like I mentioned about anxiety, it's forward thinking, takes you out of the body, out of the moment. So holding ice on your hand really brings you back into your body, into the moment. Focus on your breath. Breathe slowly, intentionally, exhaling longer than you inhale. These are some ways you can begin to manage a panic attack. Next slide. Just wanted to check in with folks about just our speed, if there's any questions so far. Also with the interpreter, how are we going with the speed of our presentation?
I'm not sure we'll be able to. Oh.
I was just about to say, folks, feel free to also write in the chat. You could also submit questions or any kind of comments, and we'll periodically look at that chat to monitor that.
Great. So I'm going to try to breeze through the next section. I want to make sure we have time for questions at the end, especially about plugging into resources. So the other most common type of psychiatric distress or mental health disorder that we come across is depression. So there are depressive disorders, and then there is kind of feeling depressed from time to time. Those are two different things. So we know that feeling sad, feeling low is a part of being a human being. It's normal. And especially when we are going through something really tough, feeling sad, feeling depressed is, kind of to be expected in a way. When we think about depression clinically, this is more than having a really bad day or even a really bad week or, 10 days or so. If we're thinking about someone who has been experiencing really low mood or I'll explain it in a second, but kind of a lack of pleasure in anything. So kind of a blah or numb feeling for a long time, 2 weeks or more, then we're starting to think about whether it's depression that we're looking at. So depression or depressive disorders are considered mood disorders since they affect our mood. They affect the way that we feel. And the way that we can distinguish a potential depressive disorder from having a tough day or a tough couple days is, first of all, how long are you experiencing it? So as I just mentioned, we're looking at 2 weeks or more most of the day and more days than not. So 10 out of 14 days, for example. One of the two things that you need to be experiencing for it to qualify for a depressive disorder diagnosis is a low mood, so feeling sad or feeling down, and a loss of pleasure in daily activities that you used to find pleasurable or that you used to find at least interesting or fulfilling. Whenever any of these changes are to the extent that they're causing some real changes in your life, and especially causing problems in getting things done or being able to connect with people that you ordinarily connect with, being able to take care of yourself or take care of people that you need to take care of, then we might be thinking about, okay, maybe this is something to really get some professional support around. And of course, if there's a point where someone is to the extent that their low mood or lack of pleasure is accompanied by increased thoughts of dying, of wanting to end one's life, or wanting to seriously harm oneself, or to just disappear and not be here anymore, then we start to get concerned and definitely want to intervene. I really want to highlight that even with all of the kind of painful symptoms that I've described, depressive disorders are really common and also really treatable. And depression can look very, very different from person to person. We'll talk a little bit about that in a minute. And these types of symptoms can emerge in response to something really tough that might be happening in your life, but also they can be due to side effects from medication, some physical conditions, and some different types of substances and substance use disorders can also lead to an increase in depressive symptoms. So these are kind of the hallmark symptoms that we're looking at when we're thinking about a diagnosis of a major depressive disorder. So up top, I don't know if you can see my mouse, but the first two are that low mood and the loss of interest or pleasure that I described. And here are some other symptoms that we're also going to be looking for if we're going to make a diagnosis. So there are 9 different symptoms, and you need at least 5 to get a diagnosis of major depressive disorder. And again, one of those 5 needs to be one of these. You can also, of course, have both. And this is just to display the diversity of the way that depression can show up in someone. And so we're looking at this in 4 different categories. On the top left, we have emotions, so sadness, anxiety, guilt, etc. We also have the way it can show up in our thinking patterns on the top right. So, making bad comments about yourself, changes in your memory or your concentration, a real difficulty with making any sort of decision. On the bottom right, we have physical changes that can show up. So the most common ones are fatigue, just feeling tired all the time, not having any energy or motivation to do things, especially the things that you need to do, and changes in your sleep and changes in your weight or your appetite. And then on the bottom left, we have changes in our behavior. So it can be behaviors that folks can readily see, like crying. It can also be a lack of being able to see each other if someone is really pulling back and withdrawing. It can also be changes in the speed that we're moving, changes to our hygiene, etc. Another mood disorder, so a disorder that refers to changes in the way that we feel, is bipolar disorder. So bipolar, so if we're picturing a kind of a pole of mood, and then on one side is depression, and on the other side is mania, that's what we mean by bipolar disorder. Previously, it was called manic depressive disorder. So mania on one side, depression on the other. It's important to note that bipolar disorder is not the same thing as having mood swings. When we're looking at bipolar disorder, we're looking at mood episodes. So depending what kind of mood episode we're thinking about, a manic or a depressive episode, there are different lengths of time that are required for this to be considered a mood episode. So depressive, as we've talked about, is 2 weeks or more. Manic or hypomanic, which is kind of a step below manic in intensity, that is between 4 days and a week, kind of depending on which type of mood episode. There's also mixed episodes where you have both manic and depressive symptoms happening at the same time. So what do I mean by manic? I haven't really explained that yet. So mania refers to abnormally elevated energy levels, mood. You might have, these really kind of grandiose ideas about yourself and what you're capable of. You might see changes in speech where someone kind of can't get the words out fast enough. They're speaking so quickly. You might see folks who, don't feel like they need any sleep and still maintain that really high energy. And again, this is when this is happening over the course of several days to a whole week. This isn't like I'm having a really amazing day and I'm feeling on top of the world. This is when that sticks around for up to a week. And we also want to just let you all know about psychosis and schizophrenia, how they're similar, and especially how they're different. So when we say psychosis, psychosis refers to a separation from reality. So that can happen in many different contexts. It can happen as a result of using certain substances. It can happen due to severe sleep deprivation. And it can happen within the context of certain psychiatric disorders, including schizophrenia. It can also happen within the context of certain medical problems. So psychosis is kind of a broad category. And this detachment from reality, especially if it's happening unexpectedly, can be incredibly scary for folks. And so it might be really challenging to figure out what's real and what is also happening within one's mind. Within the context of schizophrenia, we do require the presence of certain types of psychosis in order to make the diagnosis. So one is delusions, or kind of really kind of strong but incorrect beliefs about other people, about, you feel like this billboard is speaking to you, things like that. That's an example of a delusion, a belief that's not true, but is really hard to unhook from. And we also have hallucinations, which are sensory experiences that the person is experiencing that other people around them are not experiencing with them. So are you seeing things that other people can't see? Are you hearing things that other people can't hear? That might be a sign of having a hallucination. And then we also have what's called negative symptoms, which, so delusions and hallucinations are positive symptoms. They're things that are added on to someone's experience or presentation. And negative symptoms are things that are taken away. In this case, we're taking away emotional expression or affect. So you might see somebody who presents as, very flat, isn't speaking a whole lot, isn't expressing a whole lot of emotion. That can be a symptom of schizophrenia as well. Schizophrenia is also more common than many of us think. It affects about 1% of the population. So I'm going to skip over questions for the sake of time for now.
Dr. Gitlin?
Yes.
We had received a question, or I had received a question about making the connection with LGBTQ trauma and really how it connects. And when we were thinking about this presentation, really wanted to lay out a few common diagnoses before doing a pivot into trauma, so that we can really have lay down a framework and a foundation before we start talking about gender dysphoria. I think oftentimes as a children's clinician, when children are referred to us by their caregivers, oftentimes what they're seeing or what they're describing are going to be like disruptive behaviors, problems with peers, or problems in the home, or problems with concentrations that are often misinterpreted, right, as like a behavioral problem. But in fact, what we're really, when we apply a trauma lens to the community in general, specifically to queer populations, we begin to see a very different clinical picture. And by having an accurate diagnosis, we're able to provide appropriate interventions. So I think this is why we're laying out this groundwork, because like I said, really it's about giving people the appropriate diagnosis for the appropriate interventions.
Absolutely.
Any other additions to that, Dr. Gitlin?
Yeah, really just to hopefully empower everyone that's here with knowledge about these diagnoses. I think there's a lot of false information out there. There's a lot of stereotyping that happens around certain diagnoses, and people kind of labeling each other or labeling themselves. So we really want to make sure that you have all of the information that you need to kind of make an accurate self-assessment, or to know what to communicate to a mental health provider if you decide that that's something you would benefit from. So want to talk a bit about substance use. So substance use, I assume we all know, is super common. It is something that is very much present within our culture in the United States. And then we'll talk in a minute about its role and implications within LGBTQ plus communities as well. People use substances for lots of different reasons. One reason is to feel good, to celebrate. Another reason is to feel better. So getting through really difficult emotions or really difficult experiences. So feeling good and feeling better, I always like to remember as two of the main reasons. We also use substances in the context of certain cultural events or cultural observances. And some folks use substances as a process of spiritual awakening. The three main classes of drugs are stimulants, uppers, depressants, downers, and hallucinogens, which are kind of perception or mind altering. And using substances in these classes and for any of the reasons that are on the top of the slide can do some potentially helpful things for us. It can also potentially do some harmful things for us and our communities. And so when we're thinking about when substance use moves from just use to a potential disorder, like with many of the other disorders we've been talking about, we're thinking about the impact that it has on someone's daily lived experience. And especially if someone is having difficulty cutting back on their substance use when it is causing harm, then we're starting to consider whether there's a substance use disorder. So one thing I didn't mention before about depression and anxiety, and I'm going to repeat the same idea here. Depression and anxiety are more often found together than they are apart, right? So you are more likely to experience both depression and anxiety than only one of them. Similarly, it is very, very common for folks who have substance use disorders to also be experiencing another type of psychiatric disorder at the same time, and vice versa. Part of that kind of goes back to the reason why people use substances. So people might use substances as a way of self-medicating for psychiatric symptoms. And substance use can also contribute to the development of psychiatric symptoms. Within, oh, yes, Brian.
I was just gonna make a note about marijuana and cannabis, because in most recent research, even at UCLA Ground Rounds, which GMH is part of, really showing evidence that today's marijuana, today's weed grown, there's correlation with psychotic episodes, right? So recent researches that we've been really emphasizing for children's mental health is really to abstain from marijuana for the developing adolescent brain, which goes until 25 years old, because it really predisposes you for psychiatric conditions.
Yeah,
that was
thank you
it.
for that. So we know, as with many other different diagnoses, that LGBTQ plus folks have higher rates of substance use disorders compared with heterosexual and or cisgender peers. So if we're thinking about this again from a trauma-informed and a minority stress framework, there are a couple different reasons why we can understand this to be true. So one is, historically, we know that gay, lesbian, and trans affirming social spaces that felt really safe tended to be bars and clubs. So you'll see I did not include bi affirming bars, because when we think about bars and clubs historically in our space, many of them have not been affirming to bi plus folks or trans plus folks for that matter. But that these were kind of our safe havens. And so if these are spaces where, of course, alcohol and other types of substance use is kind of ingrained within the environment, then we're going to see more use. We also see the ways that there are some cultural pressures. I do think this is changing in our community now. But if we look at events like Pride, for example, I mean, Pride is a very party heavy event. And, we look at the, Christopher Street West Parade in West Hollywood, the clubs are all open pre-pandemic, of course. And, it's just kind of part of this cultural celebration. And of course, we are thinking about minority stress. Why might somebody start using or use more than they would have before to kind of get through this world that is hostile, discriminatory, or dismissive toward folks' lived experiences? And I also want to note that for folks who are, wanting to get linked up to substance use treatment and are part of LGBTQ plus communities, it can be incredibly hard to find a treatment community or a treatment program that is affirming for queer and trans folks. It's really hard to find substance use treatment anyway. And then especially when you're bringing in kind of the specific needs that we have around cultural responsivity, it becomes even harder.
Everything that Dr. Gitlin just described, like really having a trauma lens, how that trauma or stressful events can really affect an individual, and then that individual might want to find relief through substances, right? That really seems normal, right? That people would want relief from some stress or are not feeling well. So what is trauma? Traumatic events are shocking and emotionally overwhelming situations that may involve actual and or perceived harm, serious injury, death, or threat to physical integrity. So it's an event that's deeply distressing and disturbing. The experience or series of events completely overwhelms the individual's ability to cope or integrate the idea and emotions involved in that experience. What does that mean? Cope and integrate the ideas and emotions involved in that experience. What we find when working with folks that have experienced severe trauma is that it even begins to affect the way we organize memories, right? And this is why sometimes folks who have PTSD, affected by trauma, might have flashbacks or reoccurring trauma, because the way our brain begins to file information is a bit jumbled. We have a hard time making sense of that experience. Reaction to traumatic events vary considerably, ranging from relatively mild, creating minor disruptions in the person's life, to severe and debilitating. Common reactions to traumatic experiences include sadness, anxiety, anger, stress. This is a normal response to really abnormal events. For many people, this is a spike in post-traumatic stress in the days or weeks following the traumatic event. So really feeling like skittish about getting behind the wheel after a car accident, or maybe afraid going back to school after you were beaten up for being gay or lesbian, right? These are kind of forms of trauma that can begin to affect you in going back into those situations again. When we think about trauma, we think of trauma in really three main types: acute, chronic, and complex. Acute trauma is really mainly results from a single distressing event, such as an accident, assault, or natural disaster. The event is extreme enough to threaten the person's emotional or physical security, and it really creates a lasting impression on the person. Chronic trauma, it happens when a person exposed to multiple long-term or prolonged distressing traumatic events over an extended period of time. Chronic trauma may result from a long-term serious illness, for example, somebody who has cancer, or abuse, or domestic violence, or interpersonal violence within the home, bullying, exposure to extreme situations such as war. And then we have complex trauma. Complex trauma is a result of exposure to various multiple traumatic events over a person's lifetime or experience. The events are generally within the context of an interpersonal relationship. It may give the person a feeling of being trapped. Complex trauma often has a severe impact on the person's mind. It may be seen in the individual who has been a victim of childhood abuse, neglect, extreme domestic violence, or family disputes, and other repetitive stressful situations. Types of trauma. On the next slide, just briefly, what kind of things we consider traumatic: bullying, community violence, complex trauma, and disasters. But also I want us to be mindful of things like refugee trauma, people that are crossing the border from Honduras and enduring trauma, abuse, rape, just to get to this country. That is trauma. Terrorism and violence. Not only does it affect our soldiers, our men and women and folks that are serving our country and experiencing horrible things, but it affects our communities here, and our children and our families. Symptoms of traumatic stress in adults. You see decrease in concentration, very similar to also anxiety, right? Because it's really related to anxiety, irritability, depression, disassociation, hypervigilance. And how does it begin to look in children? And how does it begin to affect the various parts of children? In this next slide, you'll be able to see impacts of childhood trauma. So we know, like in that ACEs slide, that it begins, or it can begin to affect our cognition or how we begin to think. In younger kids, we see them having trouble attending and learning in class. We see delays in language. On the physical side, like we mentioned before, sleeping trouble, but also eating disorders, excessive eating or not eating enough. Emotionally, we could feel like we're very stressed. We have difficulty regulating our emotions. We might fly off the handle. It affects our relationships, our loving relationships, and our attachments with folks. Mental health, like I mentioned, depression, anxiety. Some of these diagnoses are very related or connected to trauma. And then behaviors. Oftentimes in children, like I mentioned, that trauma looks like a bad kid not paying attention, being rude to the teacher. But in fact, it's not a behavior disorder. It is really trauma, that there was some stress that happened in the child's attachments. Maybe the child had been removed from the home because of physical abuse and neglect and placed into a foster home that the child does not feel loved, is not being treated right, goes to school and appears to be acting up and is given some kind of report for bad behavior when in fact it's trauma. And this is why we wanted to lay down a little bit of this foundation before we jump into PTSD. Like I mentioned before, PTSD is not just experienced by folks who fight for our country or in battles. Post-traumatic stress disorder is a mental health condition that's triggered by a terrifying traumatic event, either experiencing it or witnessing it. Symptoms may include flashback, nightmares, and severe anxiety. Post-traumatic stress disorders may start within 1 week of a traumatic event, but sometimes symptoms may not appear until years after the event. These symptoms cause significant problems in social or work situations and relationships, and they begin to interfere with our daily functioning. When we think about PTSD symptoms, we group them into 4 types: intrusive memories, avoidance, negative changes in thinking and our mood, and changes in physical emotional reactions. So re-experiencing or intrusive memories, a hallmark characteristic of PTSD is really recurrent, unwanted, distressing memories of the event. These are oftentimes when people are reporting that they're having disturbed sleep and then dreaming about it, or even in the daytime having these flashbacks where they dissociate and then they go back to that event in their head. Another characteristic is avoidance. So symptoms of avoidance may be trying to avoid or thinking or talking about the traumatic event. I don't want to talk about it. Let's not even, I don't want to even have a memory of that situation. Negative changes in thinking and mood. That trauma, that stress is so stressful for the individual that it begins to change their thinking and their mood, right? They might be feeling hopelessness and sad, having trouble with memory problems. We often see, like I mentioned, that how trauma begins to affect the mind. It begins to affect the way you organize and understand your experiences. So in fact, you might have lapses of memory or not even remember the traumatic event that happened. Also changes in your emotional state of being, trouble sleeping, concentration, irritability. And like I mentioned, I'm a children's clinician by profession, and oftentimes where trauma would rear its head in children is in play. Children that were sexually abused, oftentimes I would see signs and symptoms of them reenacting that abuse. Sometimes when playing with toys and in a dollhouse. If it were domestic violence, I might see a play with a child and they're hitting things and banging things. And this is where we begin to see those re-experiencing of those moments in children really in their play. Really, I wanted to talk about PTSD, trauma, so that we can apply this lens before pivoting and handing it over to Dr. Gitlin so she can tell us about gender dysphoria. Dr. Gitlin?
Great. Before we do that, I want to check in with you, Brian, and with the group. So we have 10 minutes left. And I was told by Nicole, thank you for messaging me. The next session doesn't start till 6. I can go.
Hello, I'm talking to you. This is
I'm listening. I'm trying to do something. I'm listening. Trauma. No?
What are you doing that's so important?
So,
Kim, I think you might.
Can you guys please mute yourselves?
Great.
If you just please mute yourself. Thank you.
Yeah, so the next session doesn't start till 6. But I want to respect everyone's time here. I can stay a little bit later. I can also, breeze through so we can try to get as much done before 5:30 as possible. Just kind of want to get a pulse from everyone here where folks are at. And you can put it in the chat or if you want to unmute yourself. And
after Dr. Gitlin's explanation of gender dysphoria, we'll really be pivoting to like coping strategies, things like mindfulness, the cognitive triangle, and gratitude.
Yeah.
So I thought, definitely I would like to get cover gender dysphoria.
Oh, of course.
By maybe within the 30 minutes, so that people who have to get off, I think those are parts that we could also maybe send to them.
Yeah, continue. In the chat, people are unanimously saying to keep going.
Oh, wonderful. Great. Okay.
And they're very interested in gender dysphoria, so.
Yes. All right, then let's talk about it. So as I mentioned earlier, this is a super loaded, controversial, and I think really problematic diagnosis. So I want us to kind of go through this with the awareness that it is a formal diagnosis. And I also invite us to think more about gender dysphoria from the lens of the experience of it, rather than the label that we kind of give people. So gender dysphoria, by definition, refers to the distress. So dysphoria means distress or discomfort. So gender distress that is associated specifically with the mismatch between someone's gender identity and their sex assigned at birth or sex-related physical characteristics. So again, as with everything, when we're thinking about this through the lens of trauma-informed approaches to this work, this can be an incredibly traumatic experience to kind of have this distress and then to be navigating a world that is hostile to transgender people like our society is. So we know that experiences of gender dysphoria are associated with, not caused by and not causing, but associated with experiences of stigmatization, discrimination, and victimization, otherwise known as trauma, negative self-image, which can be that internalization of stigma or trauma, increased rates of certain certain psychiatric diagnoses. Especially we're looking at things like depression, anxiety, substance use disorders, and trauma-related disorders, and a substantial risk of suicidality or an increase of risk of suicidality. So again, gender dysphoria doesn't cause these things, and these things do not cause gender dysphoria, but we see them oftentimes happening alongside each other. I really want to emphasize again and again and again that gender dysphoria is not psychopathology. So, I do not consider it a mental illness. I would assume that Brian would agree with me. I hope that increasing numbers of my colleagues at the Department of Mental Health would agree with me. So this is not a mental illness, but what I think it does reflect is the interaction between a person and their sociocultural environment. And for us, living in a sociocultural environment that is hostile to transgender folks, we can see how this kind of sets the stage for gender dysphoria to emerge and stick around and have real impacts on someone's lived experience. Brian and I have both attended several trainings with a local expert named Aidan Olson Kennedy, who's the executive director of the LA Gender Center. And he talks a lot about gender dysphoria noise that a lot of trans folks experience. So what is that kind of consistent gender noise that somebody might be experiencing? Thoughts of, I'm not, fill in the blank enough, or is this person going to perceive me as fill in the blank? Or am I going to be treated this way if I show up as my authentic self? So that can be part of the experience for many folks, that gender noise of gender dysphoria.
And that noise can even begin before you're born, right? With some of those gender reveal parties, right? You're not even born yet, and already you're set up, or these expectations are placed on you, that constant noise, right?
Right. And even that they are called gender reveal parties, you know, when that the first of multiple since then big fires was set off because of a gender reveal party, I kept seeing on the internet that we should be referring to them as genital reveal parties, which I do think is a much more accurate term for that. Anyway, so the distress that is associated with gender dysphoria can really be triggered by the world that we live in, and specifically by these frequent experiences of navigating a world where the gender binary is so deeply ingrained in our culture and in our institutions, and the anti-transgender bias that kind of perpetuates. So some examples of this are misgendering folks. So misgendering refers to referring to someone as the incorrect gender. So using the wrong pronoun, the wrong name, or the wrong greeting. One term to just be aware of, if you're not aware of it already, is a dead name. And that refers to the name that a trans person was given at birth when that name is different from their current name. Distress can also be triggered by really intrusive questions that many trans and gender diverse folks are asked in healthcare and in other contexts about their body parts or about their gender journey, or making assumptions about what that kind of life journey and individual narrative looks like for them. And of course, the kind of binary influenced expectations that we see in our society around conforming to a binary gender, around this idea of quote unquote passing as a cis person, et cetera. So really kind of thinking about how our social construction and cultural construction of gender can really be causing harm for many folks in our community. So,
Dr. Gitlin,
yeah,
can I mention something connected maybe to gender dysphoria? Because on the comments I did see that there's many caregivers or parents here, and I just also want to make the relation to grief and loss. That, you know, really for some of the caregivers here, some of our parents here, and they might have a child or someone that they love that might be experiencing or going through a transition, that on their end, they may be experiencing some grief and loss, really because losing, or this concept of losing that child, the name is, you know, changing. And I just wanted to put that just to normalize that for folks out there, that if you're having a child going through this experience, that it's also normal for you to also be experiencing difficult feelings related to this, but also get some help and support, just like any kind of grief or loss. You know, you might be experiencing that type of denial or that type of bargaining, really to get to a place where you're in more acceptance.
Absolutely. Thank you so much for highlighting that, Brian. And I want to highlight another piece on top of that, which is what we're starting to see in mental health research, which I think is some real reason to have hope here, is the importance of supportive caregiving and supportive environments for trans folks. And actually, what folks are starting to see is that support is the key to kind of decreasing these disparities that we see with trans folks specifically, but within kind of the LGBTQ plus community more broadly as well. That when people are navigating environments, and especially growing up in a home where they're supported for being their authentic selves, we see these real differences in diagnostic categories start to melt away. So for the parents and caregivers that are here, you are so, so, so appreciated for being here, and so important for this work and for this community. So thank you for uplifting that, Brian. So now we're going to move into talking about some coping strategies. We'll talk at the end of this presentation about plugging into professional mental health resources, but we also want to make sure that you all are empowered with some strategies that you can use on your own or strategies that you can share with your community or loved ones if they're going through something really tough. Oh, you're muted, Brian.
Sorry about that. Mindfulness. Mindfulness is a type of meditation in which you focus on being intensely aware of what you're sensing and feeling in the moment without interpretation or judgment. Practicing mindfulness involves breathing methods, guided imagery, and other practices to relax the body and mind and help reduce stress. Mindfulness has been so helpful in really the application or mitigating some symptoms of stress and anxiety that as clinicians, it's just part of our toolkit when we're doing talk therapy, not just with adults, but even with little ones. I do meditation, all forms of meditations with little ones. And like it says, it's really a process of getting you in the moment and present. Like I mentioned, if anxiety is forward thinking and takes you out of your body, mindfulness is the opposite. It brings you back into your body. And I wanted to emphasize that word practice. Mindfulness is not easy, to not have judgment on yourself. Oftentimes our mind wanders like a baby kitten walking off. You got to herd them back in, but it's a practice. It really can help you get centered, slow down your breathing, really help you find some balance and reduce some stress, with also getting you completely aware and in tune with your body and that moment in time. Mindfulness. Did you want to add anything to mindfulness, Dr. Gitlin?
Yeah, I just wanted to add that, meditation is certainly one form of mindfulness.
Thank you.
And meditation can feel really intimidating or inaccessible for many people. And I get that completely. So I just want to emphasize that there are lots of different ways of being in the present moment and not judging what your present moment is, including when you're feeling something that's really kind of unpleasant. So sometimes it can be as simple as just naming in a non-judgmental way what you're experiencing. I'm noticing that I'm feeling really anxious right now. I'm noticing that I'm having repeated thoughts about what this person just said to me. And I'm noticing what's also coming up in my body. You can also practice mindfulness in eating or walking, cooking. So I really encourage, when I'm working with folks on kind of learning mindfulness for the first time, I encourage people to start with something they do every day, like brushing your teeth. So really paying attention to all of the physical sensations. How does it feel in your hand? How does it feel on your gums and your teeth, on your tongue? And just kind of noticing and describing what that experience is in a non-judgmental way. That's mindfulness.
Absolutely. I'm glad you mentioned cooking. Yeah, a part of mindfulness is really about those senses, your 5 senses. And in that panic attack slide, we talked about a way to get yourself grounded is using an ice cube, right? Because it plugs you back into your body. Similar to this. And I struggle with meditation too. Well, like Zen meditation, which is completely quiet. I'm more of a guided meditation type of person. And I cook, and I love cooking by myself and cutting, and I get into that zone moment that is completely meditative and relaxing. So we'll go on to the next slide, gratitude. What's the definition of gratitude? It's really thankfulness or gratefulness. It comes from the Latin word gratus, which is pleasing or thankful, is a feeling of appreciation felt by and or similar positive responses shown by the recipient of kindness. So practicing gratitude can benefit us in many ways, physical and psychologically. And like I said, emphasis on practice. Sometimes gratitude is an easier way to come by, and sometimes it's more challenging. Sometimes when I'm in those moments and having a hard day, I might do some positive self-talk to me. And that's a bit about gratitude, right? Giving gratitude. I'm a praying type of person. I'm a queer Christian that prays and goes to church, to a affirming Christian type of church, but definitely gratitude. Give gratitude for God for me being here and having, the ability to do the type of work that I do, and really changes my mood and everything that I'm feeling. In the next slide, Dr. Gitlin's going to really make this connection about how you can change your thinking and how it can just change different parts of your thoughts and behaviors and feeling. Dr. Gitlin?
Yeah, certainly. So, right. So one of the ways that gratitude helps us is it kind of shifts some of the ways that we are thinking about our days, about ourselves, about other people. And so this is the cognitive triangle here. And for anyone here who has been exposed to cognitive behavioral therapy, this is really what that therapy focuses on. So our thoughts, what we say to ourselves, kind of the messages that are happening in our minds, our emotions, how we feel, and our behavior, what we do or what we don't do, those three things all impact one another. So one of the ways that gratitude can really be helpful for us is it shifts the way that we're thinking toward things that we are grateful for, toward things that went well, toward things that make us feel good, etc. And that in turn is going to impact the other parts of this triangle. So, outside of gratitude, there are lots of ways to do this. What I would invite you to kind of think about in your own lives is what are some ways that you can kind of check your thinking and kind of offer yourself a more balanced thought to one that might be kind of causing you some emotional pain. So one example is if you notice that you're having the thought, I can't do anything right. One thing you might do is think about one thing that you do really well, or even one thing that you do just kind of okay, right? And so even just identifying that one thing offers you a more balanced perspective. So I can do some things right, and some things I'm not as good at. It's a more balanced thought to have about yourself than I can't do anything right. And then notice, how does that more balanced thought affect the way that you're feeling? And then how does the way that you're feeling impact what you will do from that thought, what you're willing to do from that thought, right? So we see how these all kind of impact one another. Another thing that we can shift is if you can't really find a balanced thought to go to, and that's okay. Sometimes that's really challenging. Sometimes we change our behavior instead. So I don't know if any of you have had the experience of, you're talking to a customer service agent, or, you're talking to someone on the phone.
No.
It is just a really annoying conversation. And I will never forget being coached at one point, even when you're feeling so irritable, is to smile on the other end. And that shift in behavior that I noticed for myself really shifts how irritable I am. I might be still thinking that it's an annoying phone call, but the level of annoyance that I'm feeling kind of goes down a notch. So sometimes we make small shifts in our behavior to impact the other parts of this triangle.
If I could give a child example, maybe if your kid is not feeling so good about going to school, something happened, and then mom or dad dress them up and they're like, oh, you look so handsome, mijo, right? And the kid feels good and positive about going to school, right? All of a sudden you change something and they begin to feel different. And maybe even their thoughts are like, hey, I'm not so bad after all, or I feel good, right? So that's a good child example of the.
Absolutely. Thank you. So much of what can really lead us to having experiences of psychological pain are when we feel like things are taken out of our control. And by the same token, so much of how we can get ourselves into some trouble and kind of spinning our wheels and nothing is happening is when we try to harness control over things that ultimately are out of our control. So a lot of what I do when I'm working with folks is really helping people identify what is within my control and what is within my field of concern. So the field of concern, which is this largest circle here, that focuses on all the things that matter to us, all the things that feel important, which is not the same, unfortunately, as the things that we can control. And when we really whittle it down, what we see is that our field of control is really focused on our own behavior. And that's pretty much it. So we can't control other people's behaviors, we can't control what other people think, but what we can control is what we do. So the question can sometimes become, what is the one thing I can do right now to shift the way I'm feeling or to make changes to my situation? Sometimes it's as simple as I'm going to call someone that I know will give me some affirmation, or I'm going to drink a glass of water because it's been a while, or I'm going to, lay down in bed and just take a time out, right? So really thinking about what do I have control over? And ultimately, that helps us build a feeling of empowerment and autonomy and decreases these feelings of helplessness that we can sometimes have when we're trying to control things that are ultimately not ours to control. You're on mute, Brian. Brian, you're on mute.
Sorry.
That's okay.
I was all trying to go so quick. I was saying I wanted to be mindful of our time. We got 20 minutes, so I'm going to go a little quick on this, but really wanted to talk about community connectedness.
Oh.
Can you hear me? No?
Oh, no.
Anybody hear me?
I can hear you. Antonietta, you're not hearing him?
Oh,
Is it back now? Can you hear me?
Hi, Antonetta, can you hear me now?
Are you in Spanish or English? Okay, why don't you continue because folks can hear.
Okay. I'm sorry about that. So just wanted to talk about community connectedness, really for the members of our community. Connection with LGBTQ plus people and spaces can really help reduce harmful impacts of minority stress. So it really bolsters strength and resiliency, reduces internal stigma, and really helps you grow your network of support. We have multiple intersecting cultural identities, so explore that with different communities. Step to connect with LGBT plus communities, like joining a group. We have so many virtual groups right now, so it's easy to kind of patch in. Also look at local organizations in the San Fernando Valley area, here in the Metro LA area, and really engage or volunteer. We're finding that this type of connectedness, connecting with others, really helps our mental health. And part of that connection, and something I wanted to touch upon on the next slide, is really faith, spirituality, and that connection with well-being. When we think about the whole person, about that human experience, and then that spiritual experience, really finding that connection with well-being. I wanted to mention this slide because, like I mentioned, I'm cisgender, queer Latino who grew up Catholic. So faith and spirituality is so part of my culture, my family, and me. And during that coming out process, this was probably the most difficult part for me. But really coming to terms with the fact that I didn't have to give that up, that can still be integrated within my queer identity. Spirituality is a person's deepest sense of belonging and connection to a higher power or transcendent life philosophy, which may not necessarily be related to our organized religious institution. With that being said, I want people to consider that there's many different branches and sects of one faith, of Christianity. So I want to offer that to folks that if you are a deeply faithful, spiritual person, there are homes out there for you. So don't feel like you need to abandon that, because that was part of my well-being. That was part of my connectedness. Me and my husband, right now we're attending church virtually on Sunday, but this is a community that helps supports us and loves us. And this is how we are connected to our community. And finding affirming faith. Does what is happening to you change your relationship with your faith? What aspects of your religion or faith community are helpful and not so helpful? Just really questions to consider if you're thinking about faith and spirituality as part of your guiding light. Are there other chapters or sects, like I mentioned, of that particular faith that better meets your needs and or is affirming and inclusive? And on this slide, I've included 2 search engines where you can find either a gay church or a queer church or a queer temple.
Great.
And then lastly, I think questions.
So if and when you find that these strategies that we've gone over during this presentation are not sufficient for kind of easing psychological pain that you might be experiencing, or if you are, just looking to plug into therapy because that's something you're interested in doing, we want to give you some resources to know how to go about that process. And we'll talk about this in the realm of the public sector and the private sector as well.
And I see some great comments in the chat in regards to the faith and spirituality aspect, which I really love. I think it's a part of our community that we're not talking about. Feel free to email the host or myself with any congregations that personally know are affirming, so that we can keep that in our resources to direct people to, please. Yeah. And then this slide here. So where do I begin? So a list of some resources. Definitely Department of Mental Health. We got DMH access number there, the 800-854-7771. 24/7 to get a referral for mental health, or even if you're experiencing some stress and you need to speak to somebody, you can speak to somebody on the line there. We also included NAMI, the helpline, National Suicide Prevention Lifeline, Trans Lifeline, GLBT National Hotline, and the Trevor Project, which are very specific to our population, have folks like us answering the phone. So we wanted to offer those to folks on this training.
Definitely. And just to note that Trevor Project is specifically for young folks. So if you are an adult or know an adult who might need some assistance from someone in the community, I would direct them to the Trans Lifeline and or the GLBT National Hotline. But Trevor Project is a really, really excellent source for youth. So I think the first question to ask is, what are your health insurance and financial parameters? Are you going to be using your health insurance to plug in with a provider? Are you, especially for folks who have Medi-Cal or Medicare, DMH is a great place to start, the Department of Mental Health, to get referrals both within our system, but also to other programs in the community who work with folks with Medi-Cal and Medicare. And if you have a different kind of health insurance, usually on health insurance websites, there is a place to look up specific behavioral health providers that are covered by your specific insurance plan. So I would encourage you to check that out. And if you don't want to go through your health insurance, or your health insurance doesn't cover mental health care to the extent that you need it to, then you can also look into low cost or sliding scale services. Lots of mental health therapists who have private practices have certain numbers of slots that they reserve for folks who cannot pay their full fee necessarily and want to pay either a lower fee or on a sliding scale. There we go. And so once you kind of have some options of providers that you can go see, what's really important, especially for folks in our community, is to ask, is this the right provider for me? Especially given everything we've talked about with trauma and a trauma-informed approach, minority stress, and all of the ways in which our own field has really perpetuated harm against queer and trans folks historically and ongoing in the current tense as well. So really kind of thinking about, is this the right provider for me? So, many online directories, some of them are displayed here on this slide, will allow you to do some filtering based on things like your health insurance plan, but also what are your social and cultural identities that you want to make sure your provider has some training and expertise in. And some of these websites also do therapist matching, which means like you would get matched with a provider who shares those same social or cultural identities. So especially websites like the bottom four, so starting with the National Queer and Trans Therapists of Color Network on down, those are ones where there's more of a therapist matching process that's involved. Psychology Today is the largest and I think most popular therapist directory. There's also been quite a bit of really valid criticism of Psychology Today not being completely up to date in terms of their language and their options for being affirming for folks from our community. Therapy Den is an alternative to Psychology Today, little more explicit of a social justice focus there, and more of an explicit affirming of folks with not only diverse sexual and gender identities, but also, really kind of orienting service towards Black, Indigenous, and other people of color and other historically marginalized groups. Once you find a therapist that you want to check out a little further, I would encourage you to look at their web presence. I would hope that any provider who has training and experience and passion for working with LGBTQ plus folks will state that on their website or on their Psychology Today profile or wherever they have a web presence. By the same token, I would actually say if you are going somewhere like the Department of Mental Health or seeing someone in a community agency, lots of people who work in the public sector, like Department of Mental Health, also have private practices. So if you are hooked up with someone in the Department of Mental Health, Google them. They may have their own web presence that will give you a little sense of who they are, since we know that within these huge bureaucratic systems, you don't really get a lot of personalization with like which therapist your case might be assigned to, but Google them. And if they don't have any web presence, and even when they do, I would really encourage you during that first session with a therapist or an initial phone consultation, ask them. They're asking you a whole bunch of questions about your history and your experiences. And you have the right to ask them about their training and experience as well. Not necessarily about their personal lives, of course, but I definitely want to encourage you to ask things like, what is your training or experience working with people who, identify the way that I do? And how would you define LGBTQ plus affirming therapy? And how do you practice LGBTQ affirming treatment in your office? What does that look like? If they can't give you an answer, that may be a sign that this is not the right provider for you, but a solid provider will. And that brings us to the end of our presentation. So thank you so much for your time. And I especially want to blow this slide up because we are 24 minutes past our original end time. So I am so deeply appreciative of the 10 or so folks that have stayed all the way to the end. And now I would love to take any questions or comments.